Well, I think we are ready to get started here. We were a little bit concerned about our speakers getting here, but they did make it over from the Hilton. So they headed to Baker College instead of Baker Hall first. So they got a nice tour of the campus. So welcome, everybody. My name is Vivian Ho. I'm a health economist and the director of the Center for Health and Biosciences at the Baker Institute. Thank you so much for coming here today. I see many familiar faces, and then I see some new faces. So I'm glad that you all took the time to come today and hear a terrific program on healthcare reform. The Center for Health and Biosciences has been on a kind of a growth trajectory over the last 2 or 3 years. So you'll see we have a couple of other programs that are coming up shortly. November 1st, we have a program here at the Baker Institute in the late afternoon on maternal and child health, and that's being organized by Farhan Majid, who is a fellow in global health, who just arrived last year and will probably be organizing some sort of conference next year. And we also have a program on November 3rd that's being co-hosted with Texas Children's Hospital. And on the panel there is Dr. Keonta Moore, who's also a fellow here in the Baker Institute, and that will be on the social determinants of health. So lots of exciting things going on, and encourage you to look at our website and see what we're up to. So we come to today's program, and as you know, many of you, we organize this particular conference, and we try and do multiple sessions in one day on national healthcare reform to see how we're doing. And to get the level of speakers that I like to bring to this conference, really top level national speakers, you have to organize this in January. So here I was inviting speakers back in January and February, kind of thinking, well, you know, what are we going to have them talk about? Because it was really hard at that point to figure out where we would be today. So what I chose as a strategy, you will certainly see during our keynote speaker during lunchtime, Dr. Richard Frank will be talking about the marketplace and what is going on in DC about that and what could be going on. But I also chose other speakers that are focusing on other areas of healthcare in this country that have not been getting as much attention in the press, but are significantly affecting the delivery of healthcare and health insurance in this country, either to employers and employees, workers, or Medicare beneficiaries, or physicians, as you shall see. And some of this was in response to some of the requests. I did hear from a number of physicians at the Texas Medical Center that you wanted something on physician payment reform in Medicare, so you're going to see it today. In terms of the logistics, you have the program in front of you, and you will see who's going to speak in which order. We'll go in the same manner that we have done for all these conferences. The speakers will talk for 40 minutes, and there will be no questions from the audience while they present. And then there will be 20 minutes after each presentation in which we open this up for comments and questions from the audience. The conference is recorded and webcast, so we ask when you have your questions that you raise your hand and a microphone will make it over to you, so that not only can the speaker hear your question, everyone else in the room, but anybody who's watching through a webcast will be able to tell what's going on. In terms of logistics, there are breaks that are put in the program. You'll see those there. And we have restrooms. The men's restroom is on this side, just down this hallway. The women's restroom is on that side. And I think you know where you've passed all the breakfast food, and there will be a lunchbox served for, right before the luncheon talk. So I think with that, we're ready to move on to the first speaker. And so in terms of the speakers, there is a nice descriptive bio on each one of the speakers in your program. I'm not going to read that all to you because it's just too much reading for me. So all these speakers have terrific backgrounds. I'll just say something a bit informally. Our first speaker is Neeraj Sood from University of Southern California's Public Policy School. I have known Neeraj for years. He, has covered, as you'll see with all our speakers, he's covered a number of different areas in his work, everything from HIV, AIDS research, to access to health insurance, to other broader issues. And he is going to be talking about high deductible health plans. He's doing some path-breaking research in this area. I know this has affected many of you working for large corporations, so we thought this was a good topic to kick off our conference today. With that, I'll hand it over to you. Oh, and just one other thing. I think we're, if you feel like doing Twitter, there's @Baker Institute or something like that on the Twitter feed.
Vivian, thank you for inviting me to this workshop, conference. I'm delighted to be here. Thank you, everyone in the audience, for deciding to spend your morning here, and the venue couldn't be prettier. So, I'm going to talk about high deductible health plans, and the direction I was given to me was some of the people in the audience are going to be academics, and some are going to be non-academics. So my talk is somewhere in the middle, which means neither of the parties are going to be happy. So the work I'm presenting today is not just my work. It's been co-authored with a variety of people across different institutions, including Johns Hopkins, Carnegie Mellon, University of Minnesota, Harvard, Rand, Stanford, and University of Southern California. So a lot of these individuals were my PhD students who went on to do better research. This work has been funded by the NIH, by the NIHCM Foundation, as well as the California Healthcare Foundation. So let's start with the basics. What are high deductible health plans? So the first thing is they have a high deductible, which means that if you're an individual, the first $1,250 you pay out of your pocket, and then after that your insurance kicks in. And if you have family coverage, the first $2,500 you pay out of your pocket, and then the insurance kicks in. These plans are also combined with tax-free health savings account. And when they combine them with these health savings account, they're called consumer-directed health plans. This is just a fancy business term. I think they were trying to sell, you couldn't say these are stingy plans, so they had to come up with a better term, and they came up with consumer-directed health plans. But basically, that's what a high deductible or a consumer-directed health plan is, a high deductible combined with a healthcare savings account. So if you think about this, there are two implications for out-of-pocket costs. So the first is, if you need health care, you're going to pay more out of it from your pocket. But the advantage of this is that your premiums are going to be lower, right? So it's not just like, it's not a bad deal because, if you're healthy, what you care about is the low premiums because you don't think you're going to be using health care. But if you're not healthy, then you care more about the out-of-pocket costs, and the low premiums might not be that attractive. So one of the key features of this is that it's going to be attractive for healthy consumers who have low expected healthcare use, who care just about the low premiums because they rarely go to see a doctor. But if you're seeing the doctor more often, then the high out-of-pocket cost is going to offset the lower premiums. So in some sense, the reason why I'm talking about these plans is that there has been an explosion in the market. So this shows that in 2006, only 4% of employees in the employer-sponsored market had high deductible health plans. And in 2016, this has grown sevenfold to about 29 or 30% of the employees. If you look at the individual market or the exchanges, there the number is that about 80% of the people are in high deductible health plans. So in some sense, these are not just the health plans of the future, they are the most popular health plans right now. So kind of understanding what they do is important for you as a consumer, is important for public policy, and so on. So what's the debate about these health plans? How do we what are the pros and what are the cons about these health plans? So one pro is that they are, as I mentioned earlier, that they are affordable. I've put affordable in quotes because they have lower premiums, but at the same time they have higher out-of-pocket costs. But this is one of the reasons why employers find it attractive, because they have to pay lower premiums on part of their employees for these health plans. The second reason employers find them attractive is they reduce healthcare costs. So the goal is that if you have a huge deductible, you're going to be more careful about spending your healthcare dollars. Every time you sneeze, you won't go see a doctor because you're paying out of pocket for it. So the goal here is to reduce healthcare costs by imposing some cost on consumers, or what a lot of people call by giving consumers skin in the game. And the goal is that hopefully we'll reduce these healthcare costs through making smarter or value-based decisions. So for example, if you sneeze, you really don't need to go to a doctor. So if you're reducing that kind of care, that's great. But if you have diabetes and you don't go to a doctor, that's not a smart way to reduce healthcare. So the goal was that by giving consumers skin in the game, we're going to lead, these plans are going to lead to smarter or value-based decisions. So the cons. So people who don't like these plans say, oh, all you're doing is cost shifting. So all you're doing is passing more of the burden of healthcare onto consumers, that now they need to pay more out of pocket, and you're increasing their financial burden. That even with insurance, if you have a huge bill, it's going to affect your quality of life or your lifestyle. So it's going to impose a financial burden on you. The second thing is that it might lead to adverse selection in low deductible plans. So this kind of goes back to the idea from the first slide, that these plans are going to be attractive to healthy individuals. So if there's an employer that offers, say, a generous PPO and a high deductible plan, what will happen is all the healthy people move to the high deductible plan, and then the insurance premiums for the PPO rise, because it's left with all the unhealthy people who cost more. So some people say that, over time, maybe the PPO might disappear and it's going to restrict insurance choices for people, that not everyone wants to be in a high deductible plan. So it's imposing costs on people who are outside the high deductible plan. The third thing people say is that this might reduce the use of high-value services. So you might not go to a doctor even when you need to go to a doctor, or you might not get a healthcare service even when you should be getting that healthcare service. And if you start doing that, then this might increase healthcare costs in the long run. So if you have diabetes and you don't go get for your regular checkup, you're going to end up with the complication, and few years down the line, your healthcare costs will go up. So they say that maybe these plans are too short-sighted. Yes, they might save money in the short run, but not in the long run. So whatever I've said right now is all theoretical, right? That there is I haven't presented any evidence to say which one of these theoretical points which one of these is more true or less true, and so on. So the rest of the talk, I'm going to talk about the studies we've done over the last several years, trying to see which parts of these pros versus which part of these cons are actually true. What does the data actually tell us? So if you look at the effect of high deductible plans on healthcare costs, we got data from 54 large employers across the US. And this data, we could follow individuals for over 5 years. So this was, there are several studies on high deductible plans and healthcare costs, but our study was unique in having this breadth of data, that typically people just follow one employer or one insurer, maybe over 2 or 3 years. And then I'm going to skip this part. So this is the part appealing to the academics, where we're basically saying that we use the right methods to estimate. So we use something called difference in difference analysis or intent to treat. I'm happy to take it, and if the academics have a question, I can answer that in the Q&A part of it. So what we find is that if you enroll in a high deductible plan, it does reduce costs, and it does reduce costs at least in the medium term. So in the first year, the cost reduced by about 22%, and by year 3, costs reduced by about 8.5%. So these are still fairly sizable reductions in costs. And you might say that, oh, Neeraj, this seems that the cost reduction is diminishing over time. But again, there's a technical point that these effects are identified from different employers, so we really cannot say that these effects are diminishing over time. The only thing we can say is that high-deductible health plans reduce healthcare costs. Unfortunately, we don't have enough data to say what's happening to the cost reduction over time. And what we find is that these savings are driven by reductions in outpatient and in drug spending. So there is little or no effect on ER use or inpatient use. So this gives at least some suggestive evidence that the story that you won't go see your doctor, and as a result of that, your healthcare problem will get worse and you'll end up in the ER, that doesn't seem to be happening over a 3-year time period. Or the story that you don't go see your doctor and then you end up in the hospital, that story doesn't seem to be happening over a 3-year time period. But you do see that you go see your doctor less and you consume fewer drugs, or you spend less on drugs. So we also find that the average person who enrolls in a high deductible plan, their cost in the previous year was about 25% lower than someone who remained in a traditional plan. So this basically says that the data shows that it's the healthy people who enroll in high deductible plans. So people who decide to enroll, their costs are about 25% lesser. So if you do some math, what this says is that if if you as an employer start offering a high deductible plan, and 20% of your enrollees choose to enroll in a high deductible plan, you are increasing premiums in your traditional plan or your PPO by about 5%. So there is this favorable selection effect, but it's not huge. A 5% change in premiums is still a sizable change in premiums, but it is not devastating. And what we find is employers can do 2 things to reduce this favorable selection. First is they can make contributions to the health saving account. And this kind of makes sense that basically you're making the high deductible plans more generous if your employer starts putting money in your health saving account. And if you make these plans more generous, then it's basically the people who are less healthy will also be motivated to join these plans. So therefore, the degree of selection is going to reduce. And the other thing you could do is you could kind of give a carrot. You could basically make the premium savings from high deductible plans big. And if you make the premium savings big, it attracts more people to join that plan, which reduces the degree of favorable selection. But both these things are going to mitigate the effects of high deductible plans on healthcare costs, because now you're making these plans more generous. So now, in some sense, there is this, how much do you care about reducing healthcare costs versus how much do you care about favorable selection and changing premiums in your traditional plans, and you'll have to balance those things out. So the next thing these plans do is they do increase excessive financial burden of out-of-pocket costs. So here I've defined excessive financial burden if you're spending out-of-pocket on healthcare more than 3% of your income. So if you're spending more than 3% on out-of-pocket costs, that traditionally in the literature is called excessive financial burden. You can do the same picture for 5% of your income or 10% of your income, and the results are more or less the same, that if you are in a high deductible plan, there is about a 4% or a 5 percentage point increase in the excessive financial burden of out-of-pocket costs. So again, there's a trade-off here. You're going to see this 4 or 5% increase. So there's a 4 or 5% chance that you'll be spending more than 3% of your income on out-of-pocket costs. But the advantage is that you will be spending $300 less on premiums. So now there's this trade-off. What do you care about more? Saving $300 over a year in premiums, or having a 5% extra chance that you will be spending more than 3% of your income on healthcare costs? And this trade-off becomes more stark if you are actually a low-income population. So here, low income was defined as anyone below an income of $40,000. And now what you're talking about is a 15 percentage point increase, roughly a 15 percentage point increase in the excessive financial burden. So if you're low income and you enroll in a high deductible plan, there is an extra 15% chance that you will be spending more than 3% of your income on healthcare costs. And the same story is there for people with chronic illness. Even the effects here are about 10 percentage points. So basically, if you have a chronic illness and you enroll in these plans, you're increasing your probability of having excessive financial burden by about 10 percentage points, or 1 in 10 chance. So the next kind of big question is that we've seen there are some cost savings, we've seen that there is some excessive financial burden, but these plans were really sold on this premise that skin in the games means smarter decisions or value-based decisions. And the question is that happening or not? So as economists, we think about spending as a multiplication of two quantities, price and quantity. So price is how much you pay for the service. So if the price is higher, you're going to be spending more. And quantity is how many services or what services you're buying. And if you're buying more services or more expensive services, your costs are going to be higher. So the two ways of reducing spending are either changing the quantity or changing the price. So smarter quantity choices could be you reduce the use of low-value care. So if you have back pain and you go to your doctor and get an MRI, that is low-value care, because a lot of evidence shows that the MRI does nothing to improve your health or nothing to influence your treatment outcomes or treatment choices. So the question is, if you enroll in a high-deductible plan, are you reducing use of low-value care? Or if you sneeze and you go to a doctor, that's low-value care, because it's not going to influence, it was just a sneeze, it's not going to influence your health outcomes, but it's going to incur healthcare costs. Or you could make a smarter quantity choice by increasing use of high-value care. So if you have high cholesterol, you should be taking your statins, right? Or if you have high blood pressure, you should be taking your blood pressure medications. So these medications are now generic, they're fairly cheap, and if you're not taking them, then that's not a good idea. So you want to see more people, and maybe now you say, I'm in a high deductible plan, I don't want to end up in the hospital, I better take my meds on time, right? So if a smart consumer might be thinking like that, and that would be a good outcome. Smart price choices would be, you could go to lower price providers. So you can get the same MRI done for $2,000 or $1,000, and if you're smart about it, you should be going to the $1,000 provider, not the $2,000 provider. Or you could be using lower price services, which is basically, suppose I'm taking a branded drug, I could move to taking a generic drug. Brands and generics are exactly the same chemical entity. So they should have the same effect, but I can save money. So that would be a smart price choice by moving to a lower price drug. So the rest of the talk, I'm going to focus on whether people are making smarter quantity choices or smarter price choices. And these are difficult questions to answer. So we've kind of cut it many different ways, but we cannot give you a comprehensive answer on what's going on. So the first thing we looked at was preventive care. So preventive care is perceived as high-value care, and a lot of people actually recognize that, so they carved it out from the deductible in these high-deductible plans. So basically, if you're in a high-deductible plan, preventive care is free for you. So this was even before Obamacare, that these high-deductible plans made preventive care free, because they recognized that it was high-value care. So we answer, what is the impact of enrolling in these high deductible plans on use of preventive care? And we focus on screenings for 3 types of cancer: breast cancer, colon cancer, and cervical cancer. So in theory, since the preventive care is free in high deductible plan, we should see more people using preventive care. The other thing we should think is, people are now scared of going to the hospital. They don't want, they want to avoid a late stage cancer diagnosis. So they should be taking more precautions and investing more in preventive care because they're in a stingy health insurance plan. So both these things would say that high deductible plans or consumer-directed plans should increase the use of preventive care. But how do you get your recommendation for your cancer screening? Like, would I go for a colonoscopy on my own? No, it's a very unpleasant experience. So unless my doctor just like harasses the heck out of me, I'm not doing that. But if I'm in a high deductible plan, I'm not seeing my doctor often enough, which means he or she doesn't have enough time to harass me to get my cancer screenings. So maybe that says that cancer screenings reduce in high deductible plans. Or the other is, patients just might be unaware of the fact that these screenings are free in their plan, right? How many people in this audience know what their copay for a drug is? Like, I'm a health economist, I do research on this, I even don't know that, right? We have busy lives, we don't read the fine print in what's happening in our health plan. So maybe that's the story, that they just think it's high deductible, I'm not going for the cancer screening because it's gonna cost me a lot of money. So what we find is, so again, this is for the academic audience. So what we find is that people in traditional plans versus people in high deductible plans, before they enroll in a high deductible plan, this shows the difference in their cancer screening rates. There is no difference. So they're basically going to get their cancer screenings more or less at the same rate. But when they enroll in a high deductible plan, actually before they enroll. So they basically enroll in October, and what we see is in December, the cancer screening rates in the high deductible group start to shoot up, which is in some sense counterintuitive. So if they had got the same screening in January, it would have been free. So now they're paying more for it, and why are they paying more for it? Because they don't know the fine print of their plan. So they think they're in a high deductible plan, and they're being smart. They're like, I'll get my colonoscopy in December because I won't have to pay for it in January. But actually in January, it would have been free for them, and they just don't know it. But after they enroll in a high deductible plan, basically there are no differences in cancer screening rates. So if you look at up to 2 years after that, there's basically no effect there. So it seems, and we looked at these results for people with high versus low use of physicians, and we find no effect there. We looked at, you could argue that maybe younger people should not be getting cancer screenings. If you're 45, like if you look at the guidelines, I should not be getting cancer screenings. I should get them when I turn 50. And we find that there's no difference between older versus younger people, between people who go to a physician more often versus people who go to a physician less often. So to me here, the story is people tried to be smart, but they didn't read the fine print of their plan. So they basically, we don't see big effects on these rates because they all got their cancer screenings in December, or a lot of them got their cancer screenings in December, ended up paying more out of pocket for it. So the other thing we look at is use of prescription drugs for chronic conditions. So there's a lot of evidence that you take your statins, you take your antihypertensives, that they are very cost-effective treatments, that there are a lot of clinical trials showing that they reduce cardiac events and they increase mortality. And this is also an interesting study because you buy your prescription drugs like throughout your life and more often. So once you have a chronic illness, you're getting these drugs every 90 days and so on. So it's a repeat purchase. You have enough time to learn about this, figure out what's going on. And the other good thing is that there are clear lower cost alternatives available. So in a lot of these drug classes, there are brand name drugs and there are generic drugs. And I think as consumers, a lot of us understand the difference between brand and generics. It's easier for us to, in some sense, price shop for drugs compared to doctors. If I go to a doctor who charges $200 versus $100, I don't know what the difference in quality is. But I think a lot of consumers understand that branded and generic drugs are the same thing. So it's interesting to see how people behave when faced with these choices. So people can do 3 things. So just like the cancer screenings, you can stock up on care. And here it makes sense. So in January, drugs are going to be more expensive for you. So basically what you should be doing is on December 31st, going to the pharmacy and getting a 90-day supply of your statins, right? That would be a smart way to save money. The other thing you could do is you could switch to a generic. So instead of taking Lipitor, you could say, I'm going to take atorvastatin. It's the same thing. It'll save you money. The third thing you could do is you could just stop taking your statins or your drugs saying, they're too expensive. I don't want to take them. And then that would not be a smart thing to do. So the question is, what are consumers doing? Are they saving money in smart ways or not? And we looked at 3 types of drugs for diabetes, statins, and antihypertensives. So what the first thing we find is purchases, again, do spike up in December. So they're being smart. They're buying their 90-day supply in December, and you kind of see the mirror effect of that in January they don't buy their drugs. So we kind of do see this stocking behavior, that you buy your drugs in December, and then there's a drop-off in buying drugs in January. But even if you smooth this out, so even if you take into account the stocking effect, we still find that people stop taking their drugs. So the blue line shows people who are in conventional plans, and the dotted line shows people who enroll in high deductible plans. And you see, over time, people just stop taking their drugs. They kind of act surprised, like, no one forced them to sign in these high deductible plans. They seem sometimes to be just surprised by this. And sometimes employers do force them, that some of these firms were full replacement firms, where basically the employer said, we're just going to offer you high deductibles and nothing else. So you do see reduction in day supply, or reduction in use of these drugs. For some drug classes, so for diabetes, we saw an increase in generic drug use. So again, that's a smart thing to do. And interestingly, I think when we talked to some clinicians, they said that for diabetes, actually the generics might be better than the branded drugs. So in some sense, it made sense that people were switching to generics for diabetes. And overall, when you combine all this evidence, what it says is for statins and for antihypertensives, 90% of the savings come from just stopping your drugs. For diabetes, about 70% of your savings come from stopping your drugs. About 25% come from switching to your lower cost generics, and about 7% comes from stocking. So again, like if you want to kind of have one summary picture, the picture is that a lot of people are just saving money by not taking their drugs, which is not a smart thing to do for these chronic conditions. So the other thing you could do is you could look at the use of low-value services. And so there's something called the Choosing Wisely campaign, which is basically professional. So a bunch of doctors get together, and they were charged with saying, you as anesthesiologists or you as radiologists, tell us 5 things you do which are low value. And that is basically the Choosing Wisely campaign. So all these professional societies came up with this list of 5 things they do which actually don't improve patient health, may cause them harm, and lead to more spending on healthcare. So we coded up 26 of these low-value services. So some examples of that are imaging for low back pain, imaging for uncomplicated headache, getting a spinal injection for your lower back pain, and so on. And it's interesting that when I talk to consumers, none of them say that these are low value, because they're low value from a physician who understands the medicine. For a consumer, it's like, I have back pain, you better do something you do an MRI, it makes me feel better. Right? So I think there's some debate about it. This is what economists call moral hazard, right? That consumers just want, once they have generous insurance, more care is sometimes just better, especially when they're hurting. So we looked at these use of low-value services. This was a different data set. So we still find the same finding, which is high deductible plans reduce outpatient spending, but we find no effect on use of low-value care. So again, this shows people reduce care, they just don't go to the doctor, but they're not savvy enough to say imaging for low back pain is low value and I'm not going to get it, or the spinal injection is low value and I'm not going to get it, right? And maybe physicians more or less don't know what kind of health plans their patients have, so they're not saying that, oh, Neeraj is going to pay a lot of money for this spinal injection because he's in a high deductible plan, let me not order this spinal injection for him or her. So now let's look at the other side, which is, do high deductible plans lead to smarter price choices? So this is data from a paper we published in a medical journal. So we looked at prices for insured patients within the same market, so within Houston. And what we find is that for office visits, prices can vary twofold. For imaging, prices can vary threefold, and for lab tests, pricing can vary sixfold, right? So this shows that there is a lot of variation in prices, which means if you actually price shop, you can save a significant amount of money. So if you price shop for lab tests, you could be going to a place that's 6 times cheaper, and so on. The other thing is there's also little correlation between cost and quality, or price and quality. And why do I believe that? And I inserted this for just this audience, because Bill Clinton said so. So he said, there's no correlation between what people pay and the quality of healthcare they get. But it's also said in a systematic review published in a leading medical journal that what people generally find is, even if an MRI costs more at one place compared to the other place, it's the same MRI. That a lot of the evidence says that places that charge more money don't necessarily provide better quality care. And a lot of the more money they're charging is because they have market power, that they have a brand name and so on. And you can kind of see that in another way. So this is data from Massachusetts, but I'm sure this holds in several markets. So here, the blue line is the most expensive hospitals, and the purple line is the least expensive hospitals. And if this was a sensible market, the most expensive hospitals would have the least market share. But here, the most expensive hospitals control 47% of the market, while the hospitals in the bottom quartile only control 12% of the market, right? And why is this happening? Because the most expensive hospitals are the big brand hospitals. Even though they're expensive, people don't want to price shop, they want to go to the big brand hospitals. So basically, price shopping makes sense because there's a large variation in prices, there's little correlation between price and quality, and the higher price providers control large share of the market. So what we did is, we've done this several ways. So first, what I did was, we looked at this in claims data, and we found that people were not price shopping. But I wasn't satisfied with that. So I said, I'm just going to go to the people directly and ask them what they do. So we did a survey with some colleagues at Harvard, and it was a nationally representative survey where we asked them that, before you got your last MRI or before your last doctor visit, did you even think about going to another doctor or going to another facility and so on? And basically, only 10% or 11% of the people in high deductible plans said that they did that. And then we asked them, okay, if you thought about another provider, did you at least call another provider or go to a website or do anything to compare prices across 2 providers? And only 3.8% of the people did that. So basically, there's no evidence of price shopping. And then I said, oh, maybe my theory about why people maybe it's like people really think higher priced doctors or facilities are better, and that's why they're not doing it. So we asked them, do higher prices mean better quality? And only 17% said yes. So 80% said no, higher prices don't really mean better quality. And then we said, okay, maybe they don't know that these prices vary a lot. They think if you have insurance, prices are the same everywhere. And we asked people, do prices vary? And 60% said yes, prices vary a lot. Right? And these responses were the same, more or less the same. They're statistically indistinguishable for people in high deductible plans versus people in traditional plans. Right? So again, there's no evidence here that you give people more skin in the game and they're going to be price shopping for their services. I think it's just the response we got from the surveys was 2 things. One is, they care about continuity of care. So they're just worried that if they go to some other facility, their doctor might not get their charts and so on and so forth, and they don't want to do it. Or it's just like, we don't know how to do it, this is too complicated, So in conclusion, what we find is that, there are several large employers who offer high deductible plans. The evidence is that they do indeed reduce healthcare costs. The evidence is that there is no increase in use of ER or inpatient costs, which is something we were worried about. There is evidence that there's little or no, you can kind of say there is no increase in use of preventive services, or you can say at least there's no decline in use of. So I'm giving it a more positive spin and saying there's little or no evidence of a decline in use of preventive services. The cons are that there is a modest increase in premiums for traditional plans. There is increased financial burden, maybe not for the average family, but especially for a low-income family or a family with chronic conditions. There is reduction in use of medications for chronic illness, and there is no evidence that people are becoming smarter. So no evidence of a decline in use of low-value services or increase in price shopping. So even though we've spent years doing research on this, there's one kind of missing question, which is I haven't told you how these plans impact health. So there is no study that has directly looked at, if I enroll in a high deductible plan, what happens to my health? And as consumers, that's something we really care about. So if you care about that, and if you have $5 million, I'll do the study for you. Thank you. I'm happy to take questions.
Thank you. You mentioned that one of the reasons consumers do not do price shopping is because they find it too complicated, which is true. I mean, every one of the stakeholders in this system is reluctant or skimpy in providing information for to facilitate the consumer choice. Employers could do some of that. Insurers could do some of that. Medicare is trying to do it and then is finding difficult to be able to share the information without having interested parties trying to reduce that. How do you get around this problem? I mean, consumers do find it complicated. There is a solution there, and yet it's not being implemented.
That's a great question. So what we find is that now large employers are starting to offer their consumers price shopping or price transparency tools. And what we find is if consumers actually use these tools, they do end up saving money. So what we found is if your employer offers a website where you can actually, the way it works is it's kind of, you type in your zip code and you say, I want a X-ray or a CAT scan, and it tells you all the providers who provide imaging services within a 5-mile radius. So you can kind of pick a provider and then call them, and it'll show you, given your insurance plan, how much is that provider going to cost you. So in that sense, it's an easy-to-use tool, but what we find is when employers offer this tool, only 3% of consumers actually use the tool. But once they use the tool, it does lead to savings. So part of the story is that maybe consumers are too busy with their lives and they have several other things to take care of, and it just doesn't come, like when you go buy a car, it comes naturally to you to go to different dealerships. But when you go buy healthcare, you just don't think about naturally shopping for it. The other thing, what has happened is some states have launched similar initiatives, but those haven't worked at all, because the problem with those initiatives is they don't give you prices tailored to you. So in some sense, there is no one price of healthcare. The same doctor charges different insurers different amount of money. And that's why if you just put up a price saying this is the average price charged by this doctor, it's meaningless. You want to know the price that is charged to you, not to just some average person in your market. So that's why those initiatives haven't worked at all. Also. And what I find is when people call docs, so one of the common ways people try to find out prices is they call the doctor's office. And the doctor doesn't want to disclose prices because sometimes there is a gag order. So they're basically saying that your pricing information is a confidential contract between the insurer and the doctor. Or sometimes the doctor is too busy. They have to first look up what insurance you have, then they need to look up what is the contracted price for that insurer, and they just don't have the time to do it. So one of my colleagues who actually did this study, he's a physician at Harvard who's looking into price transparency. His daughter, needed an eye surgery, so he tried to shop for care, and he basically wrote an op-ed that even as a Harvard-trained physician and professor, I can't do it. So, so in that sense, I don't want to blame the common public and say oh, you guys are lazy and you're not doing it. It is a tough problem to solve right now.
Speaking, in a high deductible plan, is the cost sharing between the patient and the insurance plan the same after they've fulfilled their high deductible? So, or are there other economic adjustments that occur once you've met your deductible?
So that depends from plan to plan, but in general, the cost sharing is more or less the same, and sometimes it could be lower in a high deductible plan because you've met your deductible. So it varies. There's no one formula.
I just wanted to make a point of that price transparency. I had personally used Healthcare Blue Book website to look at prices for radiography of the wrist, and I found it to be very useful because it gave me a range with the zip code, and I actually paid within that range almost to the midpoint. Mm-hmm. So I don't know whether it will work all over the country, all services or not, but, and I know that the Healthcare Blue Book was founded by a physician who had a similar experience to what you said. He wanted to do some surgery for his son, and he found the same physician charging $500 in one place and $1,500 in another place.
So yeah, I'm glad to hear that works. The other thing is, as consumers, you want the convenience that, like, suppose when I buy airline tickets, I want to see the price difference, and then I want to be able to buy my ticket right then and there. So if I'm shopping for a physician, I'll see a price difference on this website, but I have no idea whether this physician is actually going to see me. When am I going to get my next appointment with the physician, and so on. So ideally, you want a system where you can say, this physician is charging me $100, and I can click on a button and I can make a reservation with the physician, or make an appointment with the physician. So we can do that for airlines, we can do that for restaurants, we can do that for nearly everything but for healthcare. So hopefully things will move in that direction, and I think that will change things a lot. Yes.
Yes, I have a question about the perception of these choices by consumers. That you offer this new kind of health plan with significant differences, and people say, now I have to choose. Yeah, my employer doesn't provide me a standard plan. Now I have to make a choice, and it's quite a difference. Has there been any research on the perception of the hassle and inconvenience by consumers that come along with some of these things like you're talking about?
So there is definitely some research on that. And basically, some of that research says that when consumers are faced with a lot of choices, they might actually make the wrong decisions, or they're more likely to make the wrong decisions when faced with a lot of complicated choices. So there is not just a hassle cost, but there could be a real cost that you could end up in the wrong type of health insurance plan. And the other thing is, there's also research showing that people find health plans very confusing and complicated. So a lot of people don't know what a deductible is. So when your employer just says your deductible is X, they have no idea what that is. So there is a lot of confusion on the part of consumers in terms of just understanding health insurance. Yes.
Yes. My question is coming from traditional health insurance rather than high deductible, but I'm having trouble reconciling what I understand with what you're saying. For the regular plans at least, and maybe for high deductible, once the insurer has contracted for a price with the provider, how that is the price you will be charged. How does that, are you saying that someone might pay more or less if one has insurance A but goes to providers X, Y, and Z? I thought the price is contracted.
So the price is contracted, but so if you're in a traditional plan, what you're paying as a consumer is a copay. So, you'll have a $50 copay or whatever your copay is for the office visit, and that copay remains more or less the same as long as you go to a provider with which your insurer has contracted. If you go out of the network, then you'll pay the full price. But in a high deductible plan, when you're below your deductible, you're paying the entire cost of the office visit. And that entire cost can vary going from one physician to the other, or from one imaging provider to the other, or from one lab to the other. So like a simple rule is, if you're getting a lab test, you can actually, instead of getting the lab test in your physician's office, you can go to Quest or LabCorp, which are these chains, and they're going to be much cheaper. But a lot of times people don't even think about that. They just say, my doctor says, go get this blood work done, and you just get it done at your doctor's office.
Know that Vivian is so prescient about what she does in these setting up these agendas, but what could be better than hearing you talk about this kind of issue with what's going on in Washington today? How does all this relate to the Affordable Care Act and what's being proposed in the Senate?
Sure. So I think Richard is going to talk more about it. So I think there are two implications here. The first is there's talk about introducing less generous insurance coverage, which doesn't meet the standards of the Affordable Care Act. And what this research shows is that healthy people are going to pick up that insurance coverage, which means people who want the regular Affordable Care Act coverage, their premiums are going to rise. The extent to which that happens depends upon how stingy the new coverage is. That if it's really stingy, it's going to attract all the healthy individuals there.
Does the Affordable Care Act have high deductible plans?
Yes. So about 80% of the plans sold on the healthcare exchanges are high deductible plans.
Do you see any response on the pharmaceutical companies, how they respond? Because now you have people choosing more generic drugs, a lot of people doing so. So pharmaceutical companies, is the price dispersion in drugs decrease after more people enroll in things like that?
No, we haven't seen that. And it's basically that other than for diabetes, we didn't see a significant uptick in the use of generic drugs. And the other fact is that if you look at overall the prescription drug market, more than 80% of prescriptions in the US are generic prescriptions. So, generic use is actually very common in the US, but those 80% of prescriptions account for only 20% of spending, because the other 20% is all the branded drugs. And I think now the trend is towards these higher cost drugs. So the average specialty drug costs $50,000. That's basically our median household income. And we're a rich country. And that's twice the median household income of a Medicare beneficiary. So I think on the drug side, that's kind of the real issue. How do we deal with these new drugs that are effective, but they cost the same or more as a hospitalization? Like a new drug introduced for leukemia, it has very good health effects, but it costs $475,000. So the question is, in some sense, how do you pay for that?
You've described one of the concerning drawbacks to these types of plans as the regressive impact on lower income and chronically ill. What, if anything, does the research tell us about sort of less blunt approaches to product design, like tiered networks or reference pricing, on that list of drawbacks that you described for high deductible health plans?
So, there is evidence that if you look at, say, reference pricing, that it leads people to switch from, the more expensive care provided in hospital outpatient departments to ambulatory surgical care centers. But so basically the idea of reference pricing is we're only going to impose cost on you if you go to a higher cost provider. So you could see that maybe, but there hasn't been research done, but if you just think about the theory, you could argue that if you're low income, you're going to be more responsive to that. Right? Unless you're a single mom and you don't understand your health insurance plan, and there's a hospital right next to you, and you just go there because that was more convenient. So I think that that's an open question. But clearly there's evidence that these more targeted benefits, they lead people to switch where they're getting care. With high deductible plans, we don't see that. But it's unclear what it does to a low-income population or a chronically ill population.
So my understanding is that in some countries in Latin America, they have made pretty big strides in terms of price transparency. I'm familiar with a large healthcare system that did a joint venture in Chile, and the CEO said that there's an incredible amount of price transparency there. So curious if you've investigated that. The second question is regarding HSA accounts. And so high deductible plans are either HSA eligible or not HSA eligible. There's been a big growth in the balances under HSA accounts. Curious how that factors into your equation, whether it's kind of long-term ability to cover costs, et cetera.
So it's true. I think in several countries, there is greater price transparency. And I think one of the reasons is that in a lot of these countries, you don't have health insurance. So it's basically people are shopping for healthcare on their own. So if you go to Chile or you go to India, the hospital will put up a billboard saying how much a bypass surgery costs. You don't even have to call them. They'll be like, bypass surgery package, everything, it's like a hotel, like everything included for 100,000 rupees or something. And the hospital next door is saying prices slashed, everything included for 90,000 rupees. So, that's a very, different market. And I think it's the case there because people there do think about shopping for healthcare, and the providers are in some sense responding to that by putting up these billboards or prices. And I think the increasing balances in the health savings account, they're good and bad. They're good in the sense that people will now have more pre-tax money to pay for their healthcare. The bad thing is that if you're implementing these plans to save healthcare costs, if you have more pre-tax money to pay for healthcare, you're going to be buying more healthcare. So there's kind of the flip side of it is that consumers are better covered, but we're going to be spending more money on healthcare because it's coming from a pre-tax account.
Yes, hi. Thanks for your talk. I think I read a study that said Medicare payments to physicians are only 8% of Medicare expenditures. So non-transparency there in physician charges would be less of an issue, if that's correct anyway, as opposed to drug costs, imaging, and laboratory, which would be easy to computerize on a website with a zip code like, GoodRx for your prescriptions. I wonder, what is the cost, how many dollars go to physicians in the private market, and is transparency there therefore that big an issue? Or lack of transparency, I should say.
So the first thing is transparency is not an issue for Medicare because Medicare just tells doctors what they're going to pay the doctors. So doctors have no say. Doctors can bargain with private insurers and say, you need to pay me more or less. But when it comes to Medicare, it's the other way around. Medicare just says, we're going to pay you X and that's it. So there isn't price variation for doctor visits in the Medicare program. And I think physician visits, I'll have to look at the data, but I think it costs more than 8%. So my guess would be it's somewhere 20, yeah. So it's about 20 to 25%, and I think drug spending is around 10 to 15%. So physicians. And the other thing what we found is, so we did another study, which is if I go to an expensive physician, it's not only that physician visit costs me more. He's gonna or she's gonna, refer me to a more expensive specialist. She's or he is gonna refer me to a more expensive imaging provider, and so on. So say I live in LA, it's kind of thinking about if I go to a physician who's expensive in Beverly Hills, all the services after that are in Beverly Hills. But if I go to a physician somewhere else, then all the follow-on services are at cheaper providers. So what we found is that even if you save $50 on that physician visit, over the course of a year, a patient could save $600. There was this multiplier effect because everything else downstream was more expensive.
You mentioned using statin drugs several times. I would not use statin drugs because I've read several articles about how they harm your memory. So what do you know about statin drugs harming people's memory?
So, I'll give a caveat that I'm not a physician, but but I think in general there is a lot of clinical trial data showing that statins reduce mortality. FDA does have a warning, but I don't think it's related to memory, it's related to diabetes. And I know one of my colleagues recently published a paper showing that people who took statins had actually lower incidence of Alzheimer's disease. So it's, again, that's not evidence from a clinical trial, it's just one study. But I would say if you generally talk to a physician, and again, it depends on your risk factors and so on, but if you have the right risk factors, a lot of physicians or the clinical guidelines say, taking statins is a good idea. But I think you should, just to caveat, you should talk to your physician about it. I'm not the person to give advice on that.
Consumer deal with quality issues. You can go from one lab to another and they're certified, and so you're going to get the same thing. You can go from one drug to another and they meet certain standards. You discussed imaging, and you can get an MRI for $1,000 or $2,000. It's hard to tell which one is better. The MRI is the simple part. It's the interpretation of the MRI. Anyone can have the machine and get the imaging. How does the consumer deal with that?
So that is definitely a challenge for the consumer. But you could, so when I'm talking about getting an MRI at a different place, you could get an MRI at any place and you could still have your radiologist who you trust to read the MRI. And similarly, a lot of the lab services are regulated. They're provided by, large chains. So I don't see a big quality differential there. But the big challenge is when you're choosing a physician. And there, right now, we don't have very good quality metrics. So when I choose a physician, I go to a website and I see, okay, where did they get their degree from? If they got their degree from a branded school, maybe I say it's a better physician. But I really don't have any idea whether this physician is a better physician or not. I think some of this is going to change in the next 2 or 3 years. There is a push by Medicare and by others to come up with physician quality metrics. So I think that's going to change in the next 2 or 3 years. But that is, choosing physicians based on quality is a big challenge right now.
You started to touch on the issue that interests me most, and that is the issue of the unknown. When most of us call a physician, we have no clue as to whether he's a good physician or bad physician, and it really doesn't make too much difference what school he graduated from. How are we to analyze data, as you have, where the less capable physicians are charging less, so more people go to them? So we end up with less capable, less successful healthcare. Mm-hmm. How do we measure that in all of this statistical analysis?
Mm-hmm. No, I think for physician services, that's a big challenge. And the other thing is, so typically the way people measure how good a physician is doing is by seeing what they're doing for their patients. So for example, they might say, if you have a patient with diabetes, you should be doing an eye exam every once a year or something like that for that patient. That's good quality care. But suppose you want to use that as a quality metric for a physician, the problem is most physicians maybe have 5 or 6 diabetic patients. So now, even if you say one physician, did an eye exam on 2 patients versus another did on 3 patients, is that really a metric of the physician's quality? Probably not, because that's just one metric. There's going to be a lot of noise. Maybe there was some random chance that they did an eye exam. Maybe there was some other bigger problem they were trying to solve. So it is a very challenging problem to solve, and that's why maybe it hasn't been solved yet. The other thing in our, in our other non-healthcare lives, we rely on customer reviews, right? All of us go to Yelp or go to Amazon and just say, if it has 5 stars based on 1,000 reviews, it must be a good product, even though we don't really know the technical quality of the product. And I think for physicians, it might be, again, more complicated, that a physician with a good bedside manner might get better customer reviews, but we really don't know. Like, if as consumers we care about, is this physician going to improve my health or take care of my health? I think that's a tough problem to solve. And I right now, I don't have a good solution to that. I know things are moving in that direction. A lot of people are talking about a variety of quality metrics for physicians so that you can kind of do those comparisons, but it's going to be tough.
Given that you mentioned there's an increase in savings because there's a decrease in prescription medication use, do you think we're just pushing costs of things like breast cancer being prevented by tamoxifen and heart attacks being prevented by statins and other medications? Are we just pushing that to a later date at this point? So we're not really saving money, we're actually going to spend more?
No, you're right. Like, that's what the evidence would suggest. But no one has directly looked at that, right? Again, to look at that, you would need maybe 10 years of data. So, when we looked at that, we looked at 3 years of data and we didn't see this increase in costs. But if you stop taking your statins, it's not like you're going to get a heart attack tomorrow. It's going to take some time to unfold. And that's why I think, like, a study that really looks at the long-term effects of these plans on health. Right now, we've looked at proxies for health, whether you're taking your drugs on time or not. But a study that looks at the impact of these plans on health in the long run is what is needed. And that will, in some sense, definitively answer the question whether, how good or bad these health plans are.
Okay, well, thanks very much.
All right. Thank you.